Good afternoon. So today we have a webinar on familial exudative vitreoretinopathy, that is the rare disease of pediatric retinologists, I think. We are going to have three speakers, two coming from Spain, Oriana D'Anna, that is connected, that is a pediatric retinologist, Alejandra Daruich, that is from the Necker Hospital, and the last presentation is going to be presented by Elena Vallespín, that was here with us on genetics. So I think that we have really great speakers today. So if you agree, I think that we can start with Dr. D'Anna from Madrid with the first video, please.
Hello, my name is Oriana D'Anna. I am an ophthalmologist at La Paz University Hospital, and I'm going to give a little introduction about familial exudative vitreoretinopathy. FEVR is an inherited vitreoretinopathy that is characterized by an anomalous retinal vascularization. It was first described in 1969 by Criswick and Schepens, and is one of several pediatric vitreoretinopathies that result from congenital abnormalities in retinal vascular development. This disease has a variable pattern of inheritance and expression, and the presentation and severity can differ greatly within members of the same family. It is believed that this can happen because of the presence of genetic modifiers that can have both a protective or a predisposing effect on each subject. It is important to make a differential diagnosis with retinopathy of prematurity, Norrie disease, Coats disease, and persistent fetal vasculature. It is believed that the difference between Norrie disease and X-linked fever is that in Norrie disease, mutations involve a cysteine residue in the Norrin protein, and in X-linked fever, mutations occur in the non-cysteine residues of the same protein. It gives Norrie disease a more severe phenotype. Regarding the pathophysiology, it is very similar to retinopathy of prematurity. It begins with an avascular retina with retinal ischemia that leads to the formation of fibrovascular membranes due to neovascularization. These neovessels and membranes that are formed usually lead to vitreoretinal traction and retinal detachment. Gene mutations have been implicated in abnormal signaling of known biological pathways, including the WNT signaling pathway. WNT signaling regulates cell survival, differentiation, proliferation, and migration, and in the retina, this cascade orchestrates normal retinal vascular formation. We have a canonical pathway, and there is also a Norrin signaling pathway. They both activate beta-catenin, that is a nuclear transcriptional regulator, and this leads to an expression of target genes such as c-Myc, cyclin D1, and VEGF. All of this enables cell proliferation and differentiation in specific tissues, such as retinal vessels. Only 40 to 50% of patients with fever have a genetic mutation identified. The rest of them probably have mutations that have not been described to today. This is a very heterogeneous disease, both genetically and phenotypically. It has a high penetrance between 75 and 100%, but the expressivity is very variable. The most common mode of inheritance is the autosomical dominant, and this happens in mutations in FZD4, LRP5, and TSPAN12. On the other hand, gene LRP5 also has an autosomical recessive mode of inheritance, and mutations in gene NDP usually are X-linked recessive. In this slide, we can see the 6 genes that have been associated to the date to fever. We have FZD4 that produces the receptor Frizzle4. It is in the 11th chromosome and usually it has an autosomical dominant mode of inheritance. Then we have NDP that is in the X chromosome. It leads to an anomalous norrin that is a protein involved in capillary development and is also associated with Norrie disease. LPR5, it was the first recessive gene described. Then we have TSPAN12, ZNF408, that is the most recent gene described. And then we have KIF11, that can be linked with some syndromic features. These 6 mutations account for approximately 50% of genetically confirmed fever. The mildest phenotype is FZD4, and for example, TSPAN12 only represents 10% of fever, and LRP5 is associated with an osteoporosis pseudoglioma syndrome. NDP can be associated with hypoacusia and mental retardation, and KIF11 to microcephaly. LRP5 mutations can be associated with reduced bone mass in an osteoporosis pseudoglioma syndrome. Severe NDP X-linked mutations can lead to progressive deafness and mental retardation. DiGeorge syndrome and congenital microcephaly have been described, especially associated with KIF11, but otherwise, extraocular associations in fever are extremely rare. Usually it's an strictly ocular disease. Regarding symptoms and clinical features, it is important that we can find in these patients peripheral retinal avasculaturity. It usually has a V-shaped pattern in the temporary periphery. And we can see in this angiography, this is the inferior quadrant, we can see the vascular stop between the vascular and avascular retina. In more severe cases, we can also find retinal neovascularization and fibrosis at the junction between vascular and avascular retina, as we can see in this retinography. We can see that the neovessels and fibrosis are causing a retinal fold that is circumferential to the optic nerve. We're going to see it with more detail in the next slide. Another very typical clinical feature in these patients is the traction of the macula and retinal vessels to the temporal periphery of the retina. We can see 2 degrees. The retinography on the left is a mildest phenotype, and then the one on the right is a more severe phenotype that is causing a more severe fold. In severe cases, we have a total retinal detachment with a poor visual function, and also it is very common to find in this patient a disease asymmetry. They might have a very bad looking eye with a falciform fold of the retina and very poor vision in one eye, and the other eye may be with may have only little changes. These symptoms take a progressive course during childhood and adolescence, and usually stay latent after 20 years of age. But complications such as neovascularization, vitreous hemorrhage, and retinal detachment can occur at any age. Fluorescein angiography is very important for the diagnosis and staging. Usually, most of these patients retain a good vision, at least in one of the eyes, and around 50% of patients are asymptomatic and get the diagnosis when a younger family member is diagnosed with the disease. Usually, children and adolescents have a poorer visual prognosis when compared with adults. The disease can be divided in 5 stages, being stage 1, avascular periphery, stage 2 retina neovascularization with and without exudates, stage 3 extramacular retinal detachment, stage 4 a subtotal macula involving retinal detachment, and stage 5 total retinal detachment. The diagnosis is made by clinical examination and with fluorescein angiography. And the genetic study is also very important. The diagnosis is made in patients with typical fundoscopy changes that are born full term and without oxygen supplementation. This is because fundoscopy changes are very similar to retinopathy of prematurity. There is positive family history in less than 10% of patients. Fluorescein angiography is a very important tool in the diagnosis of this disease. More than 50% of asymptomatic family members of FEVR patients have subclinical findings on wide-field fluorescein angiography. On FEVR patients, we can find peripheral vascular abnormalities and avascularity, and this is very notorious in the angiography. It's very easy to see. Then we can find anastomosis, supernumerous vascular branching, macular or peripheral telangiectasias, and dye leakage from these lesions usually suggests that there is an active and progressive disease with neovessels that usually require treatment. In these angiographies, we can see very easy the difference between the vascular and avascular zones. In the left one, there is an inferior quadrant, and the right one is a nasal quadrant. The one of the left, you can see an hemorrhage that is blocking the image, and there is also leakage from new vessels. This is another angiography where you can see the stop or the vascular stop and the difference between the vascular and avascular retina, and the presence of new vessels and dye leakage. Both of these angiographies represent the temporal quadrant of the retina, where the disease usually is more active, and you can see many new vessels in all this area. I want to thank you for your attention. Also, I want to thank ERN for the invitation to do this talk, and to the amazing team at Pediatrics of La Paz University Hospital that we do a very important job, and it will be impossible with the help of all my teammates. Thank you very much.
Thank you, Dr. D'Anna. I think that we are going to give the floor to Dr. Alejandra Daruich, who's going to talk about the treatment of the disease.
I will talk about the management of familial exudative vitreoretinopathy. I'm Professor Alejandra Daruich from Paris, from Necker and Malade University Hospital in Paris. So it is important to say that familial exudative vitreoretinopathy is a lifelong disease with period of quiescence and exacerbation. So the most important message is that these children should be examined very regularly, every each 6 months or less, depending of the phenotype, but always using fundus photography, fluorescein angiography, and OCT. So that is the most important point, is the follow-up. The second point that is important in this disease is when you look at the literature, you will not find evidence-based reports. There is a lack of prospective clinical trials for the management of active familial exudative vitreoretinopathy in children, and there is also a variability in treatment success rates, because most studies include different stages of the disease, and most of the studies lack of genetic considerations. So you will see that most of treatment practice is not really based on evidence. So there is three strategies: laser photocoagulation to prevent retinal detachment, anti-VEGF intravitreal injection to improve exudation, and vitreoretinal surgery when retinal detachment is already present. So let's see each of these strategies. Let us start with laser photocoagulation. So laser photocoagulation aims to prevent retinal detachment. So it is indicated from the stage 2 of the disease. It's mean when neovascularization is seen in fluorescein angiography. So since stage 2, we will perform laser photocoagulation of avascular retina and or bed of capillary dropout. So is laser photocoagulation enough to prevent retinal detachment? Not always, because we found, as I told you before, variable success rates of laser photocoagulation in retinal detachment prevention. The first series that we can see in the literature from 1998 show a progression through a retinal detachment progression in almost 50% of eye that were treated by laser. Most recent series show that only 13 patients of eye will worse traction after laser. And this study found two factors that were associated with worsening this traction after laser, and it was the presence of proliferative tissue in contact with the lens and the presence of supraretinal exudate. So, as you can see here, laser photocoagulation can prevent retinal detachment, but with a variable success rate that is mostly due to the heterogeneity of the phenotype and, of course, the genotype. This is a very recent case report that I wanted to share with you. It's a 17-month-old girl before laser treatment here, and after laser treatment, 4 months after, you can see that she progressed with tractional alteration and falciform fold formation. That is to remind us that familial exudative vitreoretinopathy onset before 3 years of age increase the risk of poor visual outcome. So the phenotype, the age of presentation, the genetic variant will have an impact on the treatment that we will perform. The second strategy is anti-VEGF intravitreal injection. Anti-VEGF treatment may help to reduce exudation in this disease. But attention, it can worsen vitreoretinal traction, so it should be used with extremely caution. In this series of 2021, we can see this retrospective interventional case series that included 98 eyes with stages from 3 to 5 familial exudative vitreoretinopathy with fibrovascular proliferation and prominent subretinal exudation. And here the authors report that 50% of eye that receive anti-VEGF therapy need for vitrectomy or progress through a retinal detachment. And the clinical variables that were associated with this progression were pre-existing fibrovascular proliferation over one quadrant and persistent vascular activity after the initial injection. Authors said also that the different genetic mutation could have variable response to the treatment. This is a very recent case report that I wanted to show you because this is a 22-year-old man with only left eye, since the right eye was already enucleated, that did not respond to aflibercept injection. I don't know why he had 15 aflibercept injection, but it's proof that there was no response. And then he responded to faricimab injection, and you can see here 2 weeks after 3 injections, and the response was maintained even 6 weeks after injection with a reduction of subretinal exudation. So if we need to summarize a message for anti-VEGF place or role in familial exudative vitreoretinopathy, I will say that they may be effective in reducing vascular activity. They can help to regress an exudative retinal detachment, but should be avoided in eyes with extensive fibrovascular proliferation. It should be used with caution in severe cases, and a vitrectomy to rescue complication should be planned, or at least explain to the patient the possibility to use vitrectomy if there is a complication. And of course, this treatment should be reconsidered if vascular activity and exudates persist after the initial injection. This treatment has variable outcome due to the variable expressivity, genetic heterogeneity, and of course, differences in anti-VEGF molecules. Finally, vitreoretinal surgery. Vitreoretinal surgery will be useful when there is a retinal detachment. An scleral buckle is a procedure that should be considered for exudative retinal detachment. For hematogenous or tractional retinal detachment, scleral buckle associated or not to a vitrectomy is indicated. And again, retinal detachment rate varies in the literature with a range between 60 to 90% across different series. Preoperative factors such as tractional retinal detachment, reduced visual acuity, and falciform fold are linked to a poor anatomical prognosis. And the visual prognosis remain limited, with only 1/3 of patients achieving visual acuity greater than 210. And I wanted to show you a desperate case that we managed with a desperate strategy. This was a 14-year-old boy that was addressed for retinal detachment, but he has already under silicone oil, and he has visual acuity and hand motion. I received this patient 10 years ago. He had a scleral buckle for retinal detachment 8 months before that I received him, and he had also vitrectomy peeling and so silicone oil tamponade 6 months before. It was a LRP5 mutation in this case, and you can see that it was a total retinal detachment with exudation under silicone oil with vascular activity. So at that moment, I decided to perform an 180 retinectomy and to put under silicone oil, and the patient recovered 200 visual acuity, and it has been reattached for the last 10 years. A final point for surgery consideration and follow-up in familial exudative vitreoretinopathy is the vitreomacular interface. And of course, we have to follow this patient with OCT to follow up the vitreomacular interface. But I wanted to show you this case because it's a little bit scary because it's go very faster. This was the first picture show you vitreomacular traction with some cysts. The children had 20/63 visual acuity. It was the current follow-up at that moment. And 15 days later, the consultation, he came back because we decided to follow more closely what was happening in this vitreomacular interface. And we see that there was a partial macular hole, even if the visual acuity remains still stable at that moment. At that moment, we discussed to perform an scleral buckle because I thought I will release traction, so maybe I can avoid a progression of this lamellar hole. But before that we can perform surgery, the children came back to the emergency department with a loss of visual acuity 1 week later and a full thickness macular hole that was operated then by vitrectomy and peeling, and he could recover. But it's just to show you a case where a vitreomacular interface can change very fast, and we need really to perform close follow-up of these children. So in conclusion, the take-home message for the management of familial exudative vitreoretinopathy. There is a lack of prospective clinical trial for treatment guidance. We should perform regular examination with fundus photography, fluorescein angiography, and OZT. If neovascularization is present, we should perform laser treatment of avascular areas to prevent retinal detachment. Anti-VEGF therapy may help to reduce exudation, but can worsen vitreoretinal traction, so it should be used with caution in selected patients. Classical vitreoretinal surgery allows retinal reattachment in most of patients with limited functional outcome, and outcome may vary due to the variable expressivity and genetic heterogeneity of this disease, which remains poorly explored. So thank you, and this is the team of Necker Hospital in Paris with Professor Bremont-Gignac, that is our chief of the department. Thank you for your attention.
Thank you, Alejandra. Really scary cases, I have to say. So
Okay.
we'll give the floor to Dr. Elena Vallespín, and we will talk about genetics.
Hi everyone, I'm Elena Vallespín from Hospital La Paz in Madrid, and welcome to the genetic part of this webinar. I would like to dedicate two slides to introduce our group. I work at the Hospital La Paz in Madrid, as I told you before, like the previous speaker, and we are full members from ERN-EYE. In my case, I'm a molecular geneticist, and I am at the Medical and Molecular Genetic Institute. We are divided in different sections. Some of the sections are transversal, like pre-analytics or cytogenetics, NGS, and other more specific ones that are divided by pathologies, with a molecular geneticist like me in charge, who is an expert in that group of pathologies, such cardiopathies, skeletal dysplasia. In my case, I'm the responsible of the ophthalmogenetic groups. And from this group, we have created a multidisciplinary ophthalmogenetic unit with experts from the hospital and also with external collaboration. So also I want to introduce them. Our objective is to diagnose molecular pathologies of genetic origin. The team is composed by ophthalmologists, electrophysiologists, clinical geneticists, molecular geneticists, and bioinformaticians. And we serve both adults and children. And as we all know, it all starts with the patient, with the ophthalmology suspect and an hereditary pathology. From there, the patient is referred to genetics, where the patient and his or her family are evaluated by a clinician geneticist and a genetic counselor. And it is at this point that the genetic studies to be carried out on the patient and the family are decided. In the case of complex cases, the management of the patient is decided in committee meetings that we have every month or sometimes every week. The pathologies studied in this multidisciplinary team are those associated with the eye, of course, which we all know that are very heterogeneous, have very heterogeneous characteristics. So the main features of these pathologies are that these are pathologies with clinical and genetic heterogeneity. There are more than 600 genes described that are known to cause these pathologies, most of them implicated in the expression of proteins involved in phototransduction, photoreceptor structure, and in the cellular pathways necessary for the viability and function of the retina and optic nerve, and the morphology of the eyeball. Isolated or syndromic forms exist from most of them, and the pattern of inheritance may be autosomal dominant, autosomal recessive, or X-linked. One of these pathologies is FEVR that will be discussed in this seminar. So let's talk about just a little bit about FEVR. because we have seen before how is phenotypically, but now we are going to see what happened genetically. So the prevalence is unknown, is genetically heterogeneous. Mutations are detected in 50% of cases, and in these 6 genes that I'm so sorry, but I'm not able to pronounce every single letter in English. So I can write them here. The inheritance models are dominant, recessive, and X-linked. Positive familial history is reported to be present in approximately 20–40% of cases. The prevalence is variable. Disease varies between and within families. This is an important thing in this pathology. And the spectrum is from asymptomatic to severe vision loss. And we have both non-syndromic and syndromic phenotypes. Here we can see the phenotypes, for example, associated to two of that genes that we said before, NDP and LRP5. We can see that in both cases we have mutations associated just with FEVR here and also here, but we have other phenotypes associated in this case with deafness, that is Norrie disease, and in the case of LRP5 associated with osteoporosis. So we can see also that we have dominant or recessive inheritance depending on the type of mutation. If we also look at the mutational profile of genes associated with FEVR, all this shows the great genetic heterogeneity of this pathology that we have talked before. So we have here, these are the mutation described in the genes, and we have all over the gene a lot of mutations that we have to study in a patient with this phenotype. So considering both the clinical and genetic heterogeneity, which is the most indicated technology for the study of FEVR, the best approach is NGS, next generation sequencing. With NGS, we can study several genes at the same time. And in addition, we can find single nucleotide variants, point mutations, and we can also look for CNVs that are copy number variants. We can see if there are less or more DNA quantity in these genes. There are different strategies in NGS. We can study a custom panel with just a few genes. We can make it virtually, with a bioinformatic panel, or we can just capture only the genes that we want to study. We can make a WES, there is a whole exome sequencing, or we can make a genome, complete genome. So we have seen that NGS we can see point mutation with NGS, as well as deletions and duplication of any sites, which is why is currently the most complete technology and the one that is used first. But we also have to know that, and we can't forget that the NGS has also its limitation, but nowadays is the best technique for this pathology. So in the case of FEVR, the genetic testing, the NGS is the technique that we are going to use first. So this is the panel that we have designed in our center for studying FEVR, and we have FEVR genes. We have also FEVR-like genes because there is a phenotype that is FEVR-like, and these are that genes. And also in OMIN, we have search for FEVR term, and there are some regions and some genes that we have like research, and we are also including these genes in the panel. And also sometimes if we find differential diagnosis genes, for example, for incontinentia pigmenti, we can add that gene to our panel. We are going to make first NGS custom panel in trio if it's possible. That is always the best way to study in genetics and with NGS. But if it's necessary, we are going to use another techniques. For example, as I told before, in incontinentia pigmenti, we have to use MLPA to see deletions and duplications in the gene. So it depends on the results here. We will use sometimes another techniques. In our case, how is designed that panel that I told you? We have 1,000 genes. It's a very big panel with a coverage of 250 X, the main average of the coverage. The reason because it's so high is because it's much more better for studying CNVs. And there are some regions that we can study. For example, this cluster of genes implicated in blue cone monochromatism, or the region ORF15 that we all know. And in these cases, we have to use, as I told you before, another techniques. This panel is based on different databases and also a Spanish expert panel review. And why is genetic diagnosis important? Sometimes there are patients and also doctors that ask us why I have to do the genetics, why it's important. So that's because I always used to use these slides in the conference. First one is because we can identify the region of the pathology and have a confirmation of a clinical diagnosis. Generally makes it possible to establish the evolution and prognosis. We know that not always, but it's very important for the patient, and sometimes we can have like an idea of what's going to happen. Not always, of course, but sometimes. We can make family planning and studies to know the probabilities of transmitting it to offspring, reproductive options, diagnosis the other family members. So it's very important for the family. The treatment, if any, and therapeutic approach to the pathology. And also, and for me, it's the most important thing, the patient autonomy. They can decide what to do and where to go to patient associations or what's happening with them. We all know the complicated journey to diagnosis that the patients with a rare disease make, but thanks to networks at ERN-EYE together with multidisciplinary teams, this journey to diagnosis can be reduced. So thank you very much for your attention. I'm afraid I'm not be present at the webinar. I don't know, but here you have my email if you want to contact me or you need something. So thank you very much.
Thank you very much. I think that this has been really interesting. Thank you very much.